So, yeah, I'd like to introduce Germaine. Germaine was actually one of my supervisors. So,
But they health economics might not be always.
Thank you. Okay, well,
That's it.
okay, thank you. Thank you so much. I just want to say thank you to especially Kirsten and Emily for inviting me to be an investigator for TOJ. Kirsten was my PhD supervisor. That was a long time ago. So this is about KCAD. So, oops, sorry. And I'm an nephrologist, not a pediatric nephrologist, but I do see children become young adults in our transition clinic. CKD is a very rare disease in children, typically, but it is a very devastating disease. It affects for children's quality of life, the survival. It's a multi-organ disease, so that your bones, you're anemic, you do poorly at school just because of the fact that you're urinic. And there are multiple stages of CKD. It goes from medical stage 1 to stage 5, needing kidney replacement therapy, that is dialysis and transplantation. But even for patients with stage 1 disease, they need medications such as steroids to maintain the function, to prevent deterioration of the kidney disease. So all the medications that they use have a significant impact on the overall life participation and quality of life. And further to that, I think just like any chronic disease, this socioeconomic status and all these social determinants of health are the key drivers that can impact on the child's life. And it particularly affected our population, my population, where I work in Western Sydney, which is the western part of Sydney, and it's much of a lower SES population than probably the rest of Sydney. They have quite a number of patients from culturally and diverse linguistically population, and also First Nation population. And which is why we've developed the KCAD study. It started, I think, just after my PhD. It's been ongoing. We're up to phase 2 now. It involves about 377 participants and the caregivers, and 5 pediatric clinics both in Australia and also in New Zealand. We've included school-aged children, all stages of chronic kidney disease, from early stage to dialysis to needing a kidney transplant. Unfortunately, we're unable to broadly include patients from the CAD background and population entirely because we just didn't have the funding to actually do the interpretation. But we were broad in our sampling. And this is phase 1. Phase 2 involved younger children. And we conceived the study back in 2010, and that was when I finished my PhD person, and started the whole thing around 2011. It started with a baseline survey. The primary goal really is to see the impact of SES and outcomes in children with CKD. So SES has a key exposure with multiple mediators and lots of different outcomes. And we've done the 2 years and 4 year surveys over these periods of time. We have multiple data linkages, and we've also added on a psychiatric assessment for our subcohort of patients. The SEPs that we've collected included income, housing, employment, education, structure, and the family health. We have had a lot of information outcome measures on the child survey, which included their comorbidities, the health and quality of life, education, and academic outcomes. Noting back in 2010, there is not a lot of instruments that we could use for quality of life assessment that can be applicable to children from age 5 to age 18. So HUI really was the only one around at the time. and it really wasn't even validated for younger children. And you know, the proxy measure was also not quite well established. Nonetheless, that was the only instrument. We linked multiple data sets, as you can see here. We looked at the kidney replacement therapy outcomes using the ANSTAR registry, the perinatal outcomes, hospitalization, health outcomes, costing, which we are currently working on, mortality outcomes, and also one of the education outcomes on that plan. Not the perfect measure of education outcomes, but kind of give us an understanding of how good or how not so good our children are experiencing. So this is a very first study. This is a baseline study, which is kind of not surprising, indicating that the SES status of the family has a major impact on the overall health, and the primary outcomes of this study was actually the self-rated health. Why did we choose self-rated health? Because it was an easy measure. It was a patient-reported outcomes. It's also been used in both adults and children. This is a second study where we looked at the quality of life of children with chronic kidney disease, the baseline measure, with Anna leading the study. She was one of our PhD students, now a nephrologist, pediatric nephrologist. And again, not surprisingly, patients with very worse CKD stage needing dialysis and kidney transplantation, particularly with dialysis, a much poorer quality of life compared with children on early stage CKD. And it's driven largely by domains of emotion, pain, and cognition. And more interestingly, some of the factors that led to poor outcomes are short stature. So children with CKD have a growth hormone deficiency problem, and where they're on dialysis, and also from low-income income families. Over time, we finished the data collection around 2020, so we're able to have about 4 years of data over time, and this is a study led by Chandana Gua. Chandana is actually a parent of a child, my patient, with chronic kidney disease. She had what we called nephrotic disease at the age of 8, had a first transplant at the age of 12 from a deceased donor transplant, had a lot of complications from the side effects of the drugs, disease relapse. Thankfully, she had a functioning kidney transplant now. So she led this study, and we looked at, in her PhD, the health-related quality of life. We used acuity assessment. We got really good baseline quality data, quality of life data, but as you can see here, over time, just like any cohort studies, despite our best effort, we've lost a lot of patients over time. We also, particularly when we reached to year 4, the quality of life data was not a lot, so we lost about maybe 40%. So despite that, we pressed on and did a study, and you can see how, this is a Sandy plot, the patient changes in terms of their stages of CKD over time and how they progress with their disease stages. So, and I think most strikingly is the dialysis status. Most of the other children from different CKD stages stays pretty much the same except for dialysis. And thankfully we have our allocation system in Australia where we do prioritise our children to have a kidney transplant when they're on dialysis if they don't have a living kidney transplant. That was actually hard work to get that going because that's a huge policy change, and you'll be surprised, many nephrologists do not really like that idea. So they actually changed from dialysis to transplantation, and almost all the children, when they started off at baseline, had a transplant at year 4, except for those that are very, very difficult to match. And this is kind of reflective with our data. As you can see here, the quality of life scores remain relatively static over the 4 years period for the stage 1 to 5 patients on transplantation, with transplants. But as you can see, with the dotted line for the dialysis status, your utility-based scores went from, say, a baseline of 0.6 on average to about 0.8 over time, and continues to improve. So we looked at the specific domains, and what again drove the differences were the unfortunately, dexterity. Can't explain that. Maybe it's because they have a fistula, they can't do things with their hands. But over time, once they receive the transplant, all of these domains seem to have improved over time. So it's quite interesting, as I think this is pretty much the only cohort in the world that looked at quality of life change across the different stages of CKD in children. And you can see that most health stages relatively stable, and that's reflective of their quality of life status. We're able to show an increment by about 0.05, which to many of the children and the family, this is quite a clinically significant effect. So that's it from KCAD, and again, I'd like to thank the entire team because it's amazing effort from everybody all across Australia and New Zealand.
Thanks, Germaine. That was really interesting. I'm just wondering, do you measure the parents' quality of life during the course of the dialysis? I'm very interested to see if the dialysis is improving quality of life over time, because in adults it's often associated with a dip initially, and then perhaps over time will catch up.
Yeah, thanks for that. We've actually haven't looked at the quality of life of the adults, but we actually looked at the self-rated health of the adults over time, and we've just recently published that. Sadly though, and the outcomes was actually, the exposure was socioeconomic status and social determinants of health. So irrespective of what stages of CKD your child has, even if you had a transplant, if you belong to the very, very low quartile, your health status, even if your child had a transplant, actually drops. And that's quite a shocking finding, I think, certainly for us.
Thank you.
So with the dialysis score increasing over time, is that because dialysis is the indicator at the start, or and a reasonable proportion of those patients on dialysis actually got transplants over time?
That's right.
So the increase is not necessarily related to dialysis, it's related to the fact that they've got transplants.
So dialysis was actually treated as a time variable. Sorry.
Germaine, sorry, I may have missed this. How did you treat the loss to follow-up in the analysis?
In a mix, because it's a really mixed model, we did not impute, we just treated as a missing value. Yeah. We could have done a GEE as well, and we've actually ran a GEE, it was exactly the same, so we chose a really mixed.
Thanks for the presentation. Just, I probably missed it. What was the MOU instrument you used?
Oh, it's Huey.
Huey, thank you. Huey
Yeah.
3.
Great, thanks, Germaine. Actually, so we'll stop the morning tea, but I just wanted to comment on the question around socioeconomic. It actually led to Germaine running a trial specifically looking at supporting parents and families with kids, called NAPKids, where they used a patient navigator, which has just been finished. So KCAD, I guess, sort of is one of the prime reasons for addressing that question specifically in the trial. So, yeah, anyhow.